one time and show the room that everyone is here. We want to welcome you today to our quarterly medication training. We're going to talk about the 2012 Behavioral Health National Safety Goals. And I want to thank Michelle Kozer, our director, for allowing me to have this presentation, and for all my co-workers and peers, our resident counselors here. This presentation will address and answer the following questions. Why is the Joint Commission accreditation important to Phil Haven? What are the 2013 National Patient Safety Goals? And what is the rationale for each of the goals? Accreditation is earned. And as you know, every 3 years, the Joint Commission comes out on an on-site survey and they check our compliance with meeting standards of care. Accreditation indicates commitment to safe, high-quality patient care, treatment, and service. Accreditation gives us instant credibility and helps us attract customers. It ensures community confidence in our provision of safe practices, and it creates a focus on continuous improvement. It improves the access to contracts and third-party payer recognition. The National Patient Safety Goals were established in 2002. The goals help accredited organizations such as ours address specific patient safety concerns. Each year there's a new set of safety goals, and they are designed by a panel, the Patient Safety Advisory Group, and they're widely recognized safety experts. The Joint Commission's focus is to assure safety in the workplace. As many as 98,000 Americans die each year as a result of preventable medical errors. So here are the 2013 Behavioral Health Patient Safety Goals. The first one is identify clients correctly. The second one is use medication safely. Third one, prevent infection. And fourth is identify client safety risks. So let's talk about the first goal. Improve the accuracy of the identification of individuals served. We need to use at least 2 patient identifiers when providing care, treatment, and services. And we do this every day, don't we? We use the client's name, birth date, or picture. And the rationale for this is to be sure that the client receives the correct medication or treatment. Goal 2, using medication safely. The focus is upon risk points of medication reconciliation. We do this by coordinating information during transfers. Now, as you know, when someone goes to the emergency room, we make sure that we have their PIN sheet, which has their medication list on that. So the emergency room doctor and nurses can check that medication. They know what they take. When we receive patients, we do the same thing. We reconcile the medication, making sure it's correct. We communicate with all providers, an updated med list. So when a patient goes to the doctors, we make sure that they have their med list with them, the updated one. We want to compare all med lists for omissions, duplications, and we want to educate our patients about safe medication use. And we do a great job with this because every medication they get, they say the name of their medication, the dose of their medication, and the purpose of their medicine. We also encourage our residents when they leave here to carry a list of their medications in case of emergency. I often suggest to them to take the white binder med list, cut it out, and put it in their wallet. We also want to make sure that our medication here is properly stored. We want to make sure the temperature is right, it's not damp or wet. We want to make sure it's the integrity of the medicine. We want to make sure the pills are not broken, crumbling. And we also, God bless you, we also make sure that our medication orders are clear and accurate. We also identify high-risk medications and look-alike, sound-alike medications. And I always alert staff about when those are present. The rationale for this is it's designed to help organizations like ourselves reduce negative outcomes and patient harm. Goal 3 is prevent infection. We want to reduce infectious transmissions by staff. And we do that by following the guidelines of the Center for Disease Control and Prevention or the World Health Organization. We wash our hands for at least 20 seconds. We use hand sanitizer, unless your hands are visibly soiled. And we set goals for improving hand hygiene. There are monitoring programs within our organization. We have goals. We have a goal of 95% reaching hand sanitizer use compliance, and we are doing very well. The last I was able to get feedback about this, we were in the 85 percentile, but diversion was even higher than that, so you guys are doing a great job. We also track each program for infections, and we do a monthly report. I take care of that. And then the rationale for this is that there are millions who acquire healthcare infections while they're in a treatment program. Hand hygiene reduces the transmission of infection. And goal 4 is identify safety risks. Now, what they're looking for is to find out who is most likely to attempt suicide. We need to conduct a risk assessment, and we do that right on admission with our PI, with the psychiatrist, psychological assessment, nursing assessment, and we do it also ongoing. So we want to identify specific client behaviors, and we want to check the environment for safety risks. We also address the immediate safety of that patient and what the best setting is. Sometimes we do need to transfer people who have suicidal ideation into a higher level of care, into our inpatient unit or a local hospital. And at discharge, we want to provide our residents with prevention information. We do that on our discharge instructions. We have crisis hotlines on there and other ways for them to seek help if they become suicidal. The rationale for this is clients under a 24-hour care do still remain at risk for suicide. And we want to assess our suicide risk. Organizations must have guidelines to assess suicide. We need to recognize the warning signs, and that is the first step in prevention. We want to observe the mood and behavior as a cue for suicide risk. And generally, people really don't want to die. They are really looking for someone to listen to them, to trust, and to care about them. Clients with suicide ideation, we want to determine the frequency, duration, and intensity. And do they have a plan? So a quick suicide assessment checklist that you could actually memorize or keep with you would be, ask the question, are you suicidal? Do you have a suicide plan? Do you have the means to carry out that plan? And what can you do to keep yourself safe? And we refer to our safety plan. So now it's your turn. I'm going to ask a few questions. So, anyone. So why is it important to use 2 identifiers? Anyone?
Right person?
Right person, correct. I'm going to give the medicine to the right person.
Right dose.
And make sure they get the right dose. But we're identifying them. So why do we need a picture, birth date, or
To reduce errors.
or name? Correct. We want to make sure we get to the right patient. It's reducing error, patient harm. All right, let's move on to the next since we just have a minute. Why is medication reconciliation important? Why is it important to do that? Why do we check when they go to the hospital or they're coming to us? Why do we reconcile the medicine and make sure it's the right meds?
That's what I was going to say. I was going to say to make sure it's the right meds.
To make sure it's
that they're still getting
Give
the
the
meds
answer
that they were prescribed.
right. You want to make sure that it is accurate because if it could be an old prescription, which is the wrong dose. So we want to make sure we're giving it right. And you don't want to give a medication that was discontinued. Exactly right. So how can we prevent infections in our setting?
Washing.
Wash your hands. Yeah, there's a lot of things we can do. That is one. Gloves, our PPI. Okay, and how are residents at risk for suicide and diversion? And what can we do to prevent it? How are they at risk here? It's a community-based program, right? Does that put them at risk? And even though they're in a 24-hour setting, are they still at risk? Yeah, I mean, can they go up to the drugstore and purchase something and sneak it back, even though we check bags?
Yeah.
So, I mean, there's a lot of ways that this could play out, and to think ahead. Look at our environment. Look at our residents. Look at their history. People that commit suicide often have a history of suicide attempts. All right, well, we're going to move on. We're going to watch a YouTube called Josie's Story, and this may not pick up on the DVD, or on the video rather, but we're going to show this for the people that are here.